Okay, so tonight's been a little bit of a challenge. I thought this was the best way to address this. So I'm just going to lecture about medications to prepare you for this pharmacology proctored exam. Some of the medications that you must know. You have to know these, okay? Let's talk about statin drugs. Statin drugs are used for cholesterol, atorvastatin, simvastatin, Lipitor, Zocor. The thing you need to know is the biggest potential adverse effect of statin drugs is rhabdomyolysis, and that is deterioration of muscle tissue that can be deadly. So if the patient has a new complaint of muscle cramping, muscle pain, muscle weakness, Charlie horses, after starting a statin drug, you need to contact a healthcare provider and stop the drug. You also should never take statins with grapefruit juice, and they should be taken at bedtime. They're best absorbed. While we're on the subject of cholesterol, niacin, which is vitamin B3, is used as an adjunct therapy to lower people's cholesterol. The biggest side effect with niacin is people tend to feel this flushing feeling after they take it. And the remedy for that is to take one 325 milligram aspirin 30 minutes before they take the niacin, and they won't have that flushing feeling. Okay, so make sure you know that. Another cholesterol medication, gemfibrozil. That is a medication that's used to lower cholesterol, but it's also toxic to the liver. So you want to make sure that you're checking liver enzymes while that patient is on gemfibrozil therapy. Well, let's talk about anticoagulants. First, we'll talk about heparin. Heparin is kind of the queen mother of the anticoagulants. It can be given either IV or subcutaneously. If we need to anticoagulate a patient quickly, heparin is usually the go-to drug. The antidote for heparin is protamine sulfate. The testing that is done if a patient is on heparin is PTT, partial thromboplastin time, also can be called an APTT, activated partial thromboplastin time. It's measured in seconds, and so a normal PTT, somewhere around 11 to 13 seconds. If somebody's on heparin, that should be 1.5 to 2.5 times normal, okay? You will often see someone put on heparin, and we need to keep them anticoagulated and send them home, but we're not going to send them home on heparin. So we will get them on heparin, and we'll start them on warfarin, Coumadin. So it's not unusual to see a patient on both of those things because we want to keep them on the heparin and the warfarin until their INR is therapeutic, international normalized ratio. Their INR needs to be between a 2.0 and a 3.0. Once that happens, we will then DC the heparin and send them home just on the warfarin. With either heparin or warfarin or even enoxaparin, which is Lovenox, that's a low molecular weight heparin. All those things, they're anticoagulants, they're not blood thinners, they don't thin the blood. They slow the clotting process down, okay? You need to make sure the patient understands bleeding precautions. They should always use a soft bristle toothbrush. They should never use anything sharp like a razor. They should use an electric shaver. They should always wear a medic alert bracelet if they're on an anticoagulant. If there's an accident, some kind of an emergency, the emergency personnel need to know if the patient's on an anticoagulant in the event the patient may need emergency surgery. So we would have to make sure we give them an antidote so they don't bleed out. The antidote for warfarin is vitamin K, okay? And vitamin K is also called phytonadione. That's Phytono, Nadione, phytonadione. That's vitamin K. With other anticoagulants, they're not really anticoagulants, they're antiplatelet aggregators. So, in other words, clopidogrel, which is also called Plavix, you'll see patients on that. It's not an anticoagulant. What it does is it helps prevent the patient's platelets from aggregating or sticking together. So that's the way it prevents clots from forming. Plain old aspirin. You will often see a patient on an aspirin regimen. So if they have a cardiovascular issue, they'll be either on a baby aspirin, a low dose, which is 81 milligrams a day. They might even be on a full strength aspirin a day, that's 325 milligrams. And that's being used not as an analgesic, not for pain, but it's being used as an antiplatelet aggregator to help to prevent their blood from clotting. So these are all things that you definitely need to know. Sumatriptan is a medication that's used for migraine headaches. You want to make sure that you understand the biggest side effect with sumatriptan is a vasospastic event. So if the patient starts to complain of a crushing feeling in their chest pain or tightness, then they need to stop that medication and call the physician. Diabetic medications, I think I talked about these a little, but I'll do it again. Insulins. You have to know your insulins. So, rapid-acting insulin is Lispro. Lispro, the effect, its onset is within 15 minutes. If somebody's getting Lispro, they must have something to eat within 15 minutes of you administering that medication because it's rapid-acting. Regular insulin is the insulin that's used in a sliding scale. It is short-acting. So its onset is usually within a half hour to an hour. Its peak is usually 1 to 3 or 2 to 4 hours. NPH is considered an intermediate acting insulin. That is the only insulin that's cloudy when you look at it in the vial. And NPH, because it's intermediate acting is somewhere between 4 and 14 hours duration, okay? And then last but not least, we've got the long-acting or basal insulins, insulin glargine, which is Lantus, insulin detamir, which is Levemir. Those are considered long-acting or basal insulin. The word basal means slow and steady. So they're given once a day, typically at bedtime, and they're not ever mixed with any other insulins, okay? The insulins that you can mix are regular insulin and NPH insulin. And the way to remember that is Nancy Reagan RN or Nicole Ritchie RN, NRRN, NPH air, regular air. Then draw up regular insulin, and then the NPH insulin is last, okay? Other medications that you need to know about for diabetes would be metformin. Metformin can cause a metallic taste in the patient's mouth. They should make sure they can chew some or suck on some sugarless hard candy to get rid of that taste. Metformin is contraindicated with contrast dye. If the patient is scheduled for an angiogram or CT scan with contrast, anything where contrast dye is going to be put into the patient intravenously, metformin needs to be held the day of the test and then 48 hours or 2 days after the test to allow their body to excrete that contrast dye. Otherwise, we can put them into renal failure. And then the third thing with metformin can actually cause, as a side effect, lactic acidosis. Kind of like rhabdomyolysis with the statin drugs, but it's a buildup of a lactic acid in the muscle tissue that will deteriorate the muscle tissue as well. It can be life-threatening. So again, onset of pain, muscle cramping, muscle weakness, Charlie horses, that's associated with their suddenly taking metformin and now they're having these issues. Stop the drug, call the healthcare provider. Acarbose is an oral medication for diabetes, should be given with the first bite of every meal. Exenatide is another medication that's used for diabetes. It's an oral, and that can cause pancreatitis. So if the patient develops an onset of severe abdominal pain, stop that drug immediately. Call the healthcare provider. Some other things that you need to know with regard to diabetes, when we talk about insulins, we're usually thinking in terms of an insulin vial. Number one, once a vial of insulin is opened, it does not need to be refrigerated. It can be kept at room temperature. Don't forget it, okay? Don't refrigerate insulin. I know that you may see that at your job. It doesn't matter. It does not need to be refrigerated. You never put insulin in the freezer, right? When you open a vial of insulin, you must always put your initials and the date that you opened it, so that this way you know when 30 days have elapsed, it's got to get tossed. We also can administer insulin via something called an insulin pen. Almost every insulin out there now is available in a pen. And a pen is a little contraption that looks kind of like a pen, and it's got a dial at the end of it that you can click, 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 click to fill it up with the number of units for that patient's appropriate dose. It has needles that are disposable, okay? So, and needles are one-time use only. It's also a question. I think it's the predictor question. Make sure that the needle on the insulin pen is changed with a new needle every use. Okay, that's important to know. We'll talk about some more cardiac meds real quick because this is important. So beta blockers. Beta blockers are the laugh out louds. Metoprolol, propranolol, atenolol, bisoprolol. One of the biggest side effects with the beta blockers, B, bradycardia. They will lower the patient's heart rate. And the other thing to look out for, heart failure. Beta blockers can actually cause heart failure. If your patient is started on a beta blocker, and when you assess them, you find pulmonary edema, which would be manifested in the form of crackles in the lungs, it's fluid, or they suddenly have a sudden weight gain and swelling, edema in the lower extremities, or JVD, jugular vein distension. These are all signs of heart failure. Patient needs to stop the beta blocker. You need to contact the healthcare provider. They should be on a different drug. Other medications for blood pressure, ACE inhibitors. ACE inhibitors are the prills, right? Lisinopril, enalapril, captopril, all the prills. You need to know that they can cause a dry cough. It's the biggest side effect. And in addition, they are potassium sparing. In other words, they will make the patient's body hold on to potassium, which can make the patient hyperkalemic, and hyperkalemia problem for lots of reasons. Hyperkalemia, number one, can cause heart attacks because when you think potassium, you think muscle, and the myocardium is a muscle that makes your heart beat. So if the patient is on any of the prills, you need to make sure you're monitoring their potassium levels very carefully. Other blood pressure medications, let's talk about, eplenorone, and that's one that you definitely need to know. Eplenorone is an aldosterone agonist, and so what it does is it lowers blood pressure, but it also can cause hyperkalemia. And remember this, any drug that lowers blood pressure can lower it too much. So just keep that in mind. Like when we talk about side effects of drugs, if a drug is for lowering blood pressure, then a side effect can be hypotension, right? Makes sense. Okay. Let's talk about digoxin. That is the queen mother. Digoxin is an unclassified antiarrhythmic drug, very old drug. Can be called digoxin, can be called lanoxin. Digoxin is one of those medications where we have got to do serum drug levels on the patient. Therapeutic drug level for digoxin, 0.8 to 1.2. Anything greater than 1.5, the patient's becoming toxic. Anything greater than 2, they're toxic. Early signs of dig toxicity, anorexia, loss of appetite, GI disturbances, GI upset, stomach upset. As it starts to progress, the side effects or the signs of toxicity can progress to severe bradycardia, severe dysrhythmias, and also blurred vision and green and yellow halos in the visual fields. If they're having those signs or symptoms, then they're toxic and they need to go to the hospital. And the antidote for digoxin is Digibind. A risk factor for dig toxicity, by the way, is the potassium level. So patients' potassium level needs to be monitored. Hypokalemia can lead to dig toxicity. So, furosemide, bumetanide, the loop diuretics, hydrochlorothiazide, chlorthalidone, the thiazide diuretics, they are potassium depleting. Because of that, if the patient's on dig and they're on a thiazide or a loop diuretic, they're a higher risk for dig toxicity just because they're on that diuretic, and they could become hypokalemic, which will make them get toxic faster. Make sure you know that. Okay. Other diuretics, spironolactone is the one diuretic that is potassium sparing. So it does not deplete potassium from the patient, but it actually makes them hang on to potassium. So that can cause hyperkalemia. So if the patient is on a pril, like lisinopril for their blood pressure, and they're on spironolactone, a diuretic, both of those medications are potassium sparing. So now you as the nurse are going to be on the lookout for the patient to become hyperkalemia. When you're teaching a patient about potassium, an easy way to remember foods that contain potassium is to take the word potassium and write it up and down on your paper, when you get your scrap paper before your test starts. So in other words, write the letter P for potassium. P stands for potatoes. O stands for oranges. T stands for tomatoes. A for avocados. S is in the word fish. Also, the next S is for spinach. And what I'll do is I will write this one out and I'll put this cheat sheet up for you as well, so you can remember foods that contain potassium. Everybody knows about bananas, right? So it's usually not one of the answers. It's going to be something weird like avocados or potatoes or something like that. Muskmelon, like a cantaloupe or a honeydew. Those foods all have high levels of potassium in them. You need to know all that. Let's see. So we talked about anticoagulants, antiplatelet aggregators. We talked about diuretics. We talked about digoxin. Oh, nitro. Got to talk about nitro. Nitroglycerin is a vasodilator, and it comes in a lot of different forms. So you can get nitroglycerin that's fast acting, that's sublingual, or buccal spray. With the nitroglycerin that's sublingual or the buccal spray, the dosage is either 1 tablet under the tongue every 5 minutes times 3 doses. Call 911 if pain is not relieved after the first dose. Or with the buccal spray, it's 1 spray into the mouth every 5 minutes times 3 doses. Again, if pain is not relieved after the first dose, call 911. Okay. Nitroglycerin sublingual tablets come in a little brown bottle. The bottle is glass and it's brown for a reason, because those pills are sensitive to sunlight. You need to store those pills in a cool, dry place. They can't take heat or sunlight. So don't put them on the windowsill. Don't keep them in the glove compartment of the car. Tell the patient they have to replenish that bottle of nitro every 6 months, whether they need it or not. With nitro, make sure the mouth is moist. If their mouth is dry, when they're getting ready to take a sublingual nitro, you can give them a sip of water to moisten their mouth so that that pill will disintegrate under their tongue and that it actually works. If they feel a burning or tingling sensation in their tongue when they take the nitro, cool. It means it's working. Okay, that's a good thing. They can also have a flushing feeling after they take that first dose. Why? It's a vasodilator. It helps angina because it opens up all your blood vessels and lets all the blood just flow nice and easy. So they're going to feel and look flushed. That's normal. Their blood pressure is going to drop quickly. Make sure they're in a seated position. They should not make any positional changes quickly. And they're probably going to get a headache from all the blood rushing to their head. It's normal. It's an expected side effect. Tell them that they can take acetaminophen as long as it's not contraindicated to help with that headache. Okay? Nitro comes in a nitro paste and a transdermal patch. For the nitro paste, there is a paper applicator that has calibrations on it, just like a ruler. So it's got a 1/4 inch, a 1/2 inch, 3/4 of an inch, an inch, an inch and a quarter, an inch and a half, an inch and 3/4, 2 inches. And so the order will read nitro paste 1 inch daily. So you'll take the paste, squeeze it from the tube onto that applicator paper that's calibrated to the ordered dose, 1 inch or whatever it is, apply it to the anterior chest wall, and you'll put a clear dressing over it to keep it in place. On in the morning, off at night, no more than 12 hours, okay? The nitroglycerin transdermal patch, kind of the same principle, except it's in a patch. And the patch, same thing, on in the morning, off at night. 12 hours on, 12 hours off. Side effects are all kind of the same as far as, the hypotension can occur, headache can occur. When the patient is utilizing a patch, it should go onto the most hairless area that you can find. You must always rotate sites of patch application. When you're removing a patch from a patient, and I don't care if it's nitro or fentanyl or what it is, when you take the patch off, you must fold the patch into itself. So in other words, if the patch is on like this, when you remove it, you fold it into itself like this and then dispose of it like that, okay? So that you are not getting any of that medication on you. And always wear gloves when you're applying or removing any type of transdermal patch. All right, so we did DIG, we did the anticoagulants, diuretics. I think that's going to be a good start. I will record another lecture, and I'll get that up tonight as well for respiratory meds and any other meds that I think you need to understand. Actually, I think I'm going to go over some of the sedatives and hypnotics and those kinds of drugs because I don't know how much you know about those either. All right, so ta-ta for now. More to come. Peace.